Last but not the least, in this session for guidelines, I request Dr. Suresh Vijan to speak on ESC guidelines for ACS.
Which is the pointer?
Control L. Yeah, it is good. It is arrow now.
Okay, fine. Okay. First of all, I must thank Dr. Satyavan Sharma for asking me to come and talk to you about the latest ESC guidelines. And when I looked at that, I said, yes, he's picked me out very nicely. A huge guideline, and I got to talk in 10 minutes. Okay. Excellent. Thanks. So, there have been quite a few changes in the new guidelines. The first and foremost has been the clubbing of unstable angina, non-ST elevation ACS, and MI in one guideline. The reasoning is very clear. After the initial triage that will occur either in the emergency room or while in the hospital, rest of the treatment, which is preventive, anti-thrombotic, antiplatelets, anti-lipids, remain the same across all three categories. So I think it makes intuitive sense to have one guideline rather than go through three guidelines. So I think they should be commented on that. They highlight one important thing, which is first and foremost, an A for an abnormal ACG, C for what is the clinical context in which you are seeing the patient, and third is the patient stable or not? And they use these three parameters to decide what you should do for a patient in which category. There is, for funds, a very strong emphasis on management from the point of admission to follow-up. Working diagnosis, as they say, is something that patient comes in with, and what is the final diagnosis after going through all the procedures that you've done has been highlighted. Also, a very long-term approach has been taken for management of these patients who come in with an ACS, but what after that, carrying on for years on together. And for the first time that I can recall, in the guideline committee, there is a patient representative who's not a doctor. So you have a patient, layperson perspective on the guidelines, how they should be done, what should be done, and that's kind of influenced a lot of the things that will come through in the guidelines. So I'm going to start talking about what is required. One, ACS is a huge spectrum: unstable angina, non-ST elevation, STEMI. ACS again, in terms of assessment of the patient when they come in. When the patient comes in, one of the first things that the guideline is unequivocal about is an ECG should be done in 10 minutes from arrival with first medical contact, which could be an ambulance, which could be an ER doctor, it could be a primary physician. But an ECG needs to be done within 10 minutes, and they are very unequivocal about it. They want that done, one. Then, based on the ECG, you look at what's happening. Either the ECG is abnormal, i.e. ST elevation, then it's an ST elevation myocardial infarction. The pathway is very clear. Primary angioplasty would be the first choice. However, and they have very clearly mentioned that if you cannot do a primary angioplasty within 120 minutes, you should thrombolize the patient. And they are very clear that do not delay thrombolysis just because the lab is not free. And lab will be free in 3 hours. No, thrombolize the patient and then take it up later as a post-thrombolysis angiography and see what you're finding. The other thing is, if the patient has just ST segment changes, he has high-risk features, so they class that as a very high-risk non-ST elevation myeloma, for which they recommend immediate angiography and PCI if required. And for the third group, which is just high-risk, so risk is slightly less than what it is in the high-risk patient, early angiography, perhaps within 24 hours of admission, unless the patient is clinically unstable, then he becomes a high-risk patient. So these are the three groups at which the first thing they say is, think of an anti-thrombotic drug. First, now what? Aspirin, mainstay for every case unless there's allergy, along with a PY2 inhibitor. Timing of each of them, we'll talk about different categories of patient, and of course, the use of anticoagulant therapy, either heparin, or low molecular heparin, or bivalirudin, or fondaparin, depending on what is the timing of the invasive procedure. Like for fondaparin, they recommend, if you're going to do the procedure 3-4 days later, keep the patient on fondaparin or other things. And at every stage, the emphasis is, somebody's coming with the ACS, think of revascularizing. What would depend on what the presentation was, what he found on subsequent investigation, if at all, and then take up with other things such as polypharmacy. And what they insist, right from day one, start thinking of secondary prevention. So high-dose statins to be taken, lipid-modified drugs, stop smoking, and other things that we do, rehab, etc., should be started while the patient is still in hospital and not deferred for later. We'll talk about it when the patient gets discharged. They're strongly emphasizing that should not be done. So that's the spectrum we see of ACS. On the patient could be virtually asymptomatic or mild symptoms, some symptoms, increasing symptoms, comes in cardiogenic shock, frank heart failure, or has a cardiac arrest outside the hospital. That's your secret. And the ECGs could be normal in the first case, some ST segment depression, ST elevation, or a malignant arrhythmia presenting for the first time for a patient with acute coronary syndrome. The cast is non-ST elevation and ST elevation. Coming to troponins. Now, the guidelines are very clear. They are talking of high sensitivity troponin that is done in the lab. They are very categoric against using point of care troponins. They say they are not that sensitive nor that specific, but they understand and give a nod to the fact that it is convenient to have these available by the bedside so you can triage faster. But their recommendation is that if you can do the HS troponin from the lab. And then the final diagnosis would be unstable angina where ECG didn't change much, there wasn't any elevation of troponin, you have other or any ST where you've seen this, and of course ST elevation where you have got clear-cut ST elevation, you're going to proceed to palming. So what have they recommended which is new? In patients with ACS who you've done an angiogram and requires to undergo bypass surgery, it's okay to stop antiplatelet agents for the surgery, but after surgery, within a couple of days, restart these and continue this for 12 months. It's a class 1 indication, though there is no randomized trial to back that up, but general consensus it is to do that. In older patients, especially if you're worried about bleeding risk, clopidogrel as a PY2 inhibitor should be considered as a class 2B indication. So giving you some leeway to chop and change what you want to do, and there is some evidence base to tell you that using clopidogrel as monotherapy probably is good. What about something alternative do you want to think of? Already mentioned by Dr. Akshay, those patients who are event-free after 3 to 6 months of dual antiplatelet therapy, who are not at a very high risk. What is ischemic high risk? Multiple stents, long stents, unstable, etc. A single antiplatelet would be preferable and should be considered class 2B indication, but there is enough randomized trial evidence to back that. And instead of continuing aspirin, you may just want to continue one PY2 inhibitor, which usually is clopidogrel. That again is a class 2B, slightly softer indication, but again, the data available for them is pretty strong. So I'm surprised that they didn't go into class 1. In high bleeding risk patient, that's an important concern for all of us. Aspirin single or one PY2 inhibitor for 1 month after DAPT may be considered, and after that stopped, and then you continue with just one. In those who are requiring oral anticoagulation, particularly patients who have AF, clearly you're going to be triple therapy for 1 month, and after 6 months you could withdraw all antiplatelets and just leave them on oral anticoagulants. That's fine too. Clearly what is not recommended is de-escalation of antiplatelet drugs within 30 days of the angioplasty. Not a good thing to do. Wait for 1 month before you do anything about it. It's positively harmful. What about patients with cardiac arrest who have arrested outside the hospital? When should we do neurological evaluation? They say after the patient is revived and is in a stable hemodynamic rhythm, do not do any neurological evaluation for 72 hours. There's too much of fluid state post-arrest injuries there. Makes no sense. Don't do it. Class 1 indication not to do. That's important. And of course, transport most patients who have arrested to a hospital where you can manage these patients appropriately. Now come to the technical aspects of invasive. Most of you are invasive cardiologists, so clear this is important. Patients with spontaneous coronary artery dissection, which do form a sizable number of our angiograms that have been done, should not be intervened unless you have symptoms and signs of ongoing myocardial ischemia. There's a large area of myocardium at jeopardy, and there is reduced antegrade flow. Important. Reduce antegrade flow. So you would actually do something and improve that antegrade by treating it. So that's an important issue. I haven't highlighted it, but that's what it should be. As far as intravascular imaging is concerned, there's a debate going on all the time. That's why it's a class 2 indication, but there is now good evidence accumulated that imaging is helpful. However, which imaging, intravascular ultrasound or optical coherent imaging, I think this is a class 2B indication, and it's usually a recommendation of expert committee, simply because I think most people are comfortable interpreting OCT images as compared to IVUS images, and that's probably the reason why it is a 2B with a C indication. Multivessel patients with ACS presented with cardiogenic shock, here the debate starts. They recommend that non-infarct related artery should be treated and you should stage it. and it's a class 2B indication. Again, consensus opinion, no randomized trial to help us do that. What about multivessel disease patients who are hemodynamically stable? Sorry, the first one was cardiogenic shock, my mistake. Those who were stable, undergoing PAMSA, they said that you do that within the next 45 days, or if the patient is stable enough, you can finish the whole week off in the first procedure itself. So for ACS, which is stable, you may wish that. But again, if you're looking at what should be done, it's a class 3 indication. If you want to do a non-infarct-related artery, evaluating the severity of non-culprit artery by functional testing is not recommended during the current admission, because you have a huge hemodynamic and adrenergic drive causing a lot of changes in the vasculature, and you would get wrong information or misinformation to take a decision. So that's certainly strongly recommended not to do. So another controversy, when should you implant a pacemaker in someone with a high degree block? Most of us would wait for 2 to 3 weeks before we do that, but their recommendation in the class 1 recommended that within 5 working days of a myocardial infarction, if patient has a high degree AV block, you should implant a pacemaker. Again, this is not based on randomized data, it is just an opinion of expert committee. Something that can be discussed, because clearly that is an issue for most of us as to how long you should wait. CMR should be considered for echo images, or if you have LV thrombus available. Sorry, I got to go
1
faster.
minute on.
Yeah, so I'll go faster then. Recurrent arrhythmias, etc., you should sedate the patient before you start running into many drugs. Okay. Again, comorbid conditions should be dealt with as prescribed, which is diabetes, CKD. Frail older patients need to be considered here, where patient inputs come in as to how much they want to do, what they want to do. Cancer is another thing. You should not intervene in anybody who has a cancer with a prognosis of less than 6 months. More than 6 months, treat them like any other patient. Okay, let me go faster. Long-term treatment, of course, intensification of lipid therapy. The patients are on lipid therapy. When they come with the ACS, you need to aggressively increase the anti-lipid treatment while the patient is in hospital. So if they're just on statin, low dose, high dose statin, add in STBB, use a PSK9 if the levels are very high, etc. And for the first time, combination therapy is being recommended as the standard of care today for patients with ACS and high lipids. Of this, I can skip that. Post-discharge discussion with patient. This is where the patient, lay patient's input comes in, as you need to inform people, you need to tell them what to do, etc., etc. And the changes are not that many, very soft indications from 1 to 2B in most of the things, cases from 2017 and 2020. So I'm going to jump over all that because that's something which is fair. And Minoka is something that makes a big mention in this ACS document. So they recommend CMR as something that you should do while you're waiting for a final confirmation diagnosis. Problem with CMR is not available everywhere, so it may have to be done as an outpatient rather than inpatients. Management depends on what the final diagnosis is. So as far as the headline, Minoka is a working diagnosis. The final diagnosis will depend on the results of the investigation that you're going to do. What are the gaps? Very important, we need to understand that. Most of the trials that they've looked at have men. More than 70% of the trialists are men. Patients are men. We make decisions on women based on 30% of the data. So we need more evidence for treatment of ACS in women. Therefore, there should be an increase and active recruitment of women in clinical trials so that the number comes to 50%. Again, older people are extremely underrepresented, above 65, 70. Very few patients take part in the trial. And I think we need to have trials looking at elder patients. And STREAM 2 probably is the first trial that looked at thrombolytic therapy in the elderly. Thank you very much for your attention.
Thank you. Thank you for excellent talk. Please join the dais. And I request...
Dr. Hetan?